You're listening to the RN Mentor, a podcast designed to document and bring you the work and experience of some of the most influential nurses in our profession. We will be sitting down and having a discussion with the leaders of today's nursing world as they share their work, how they navigate their nursing path, and their views on the future of the profession. My name is Ali Tayeb. I am a registered nurse, United States Navy veteran, a Jonas Veterans Healthcare Scholar, and your host for the RN Mentor. Hello, and thank you for joining us again for another episode of the RN Mentor podcast. I am being joined by Dr. Norma Cuellar. Dr. Cuellar received her bachelor's degree in nursing from the University of Southern Mississippi, her master's degree in nursing from Louisiana Health Science Center, and her doctorate of science in nursing from University of Alabama at Birmingham. She completed a postdoctoral fellowship from the University of Virginia in complementary and alternative medicine. Dr. Cuellar expertise is in issues around cultural diversity. Her research focus has been in diversity, sleep, and complementary and alternative medicine. She has an established career in teaching at the undergraduate and graduate program, has mentored many students and developed a program specifically including a mentorship program from Latino students advancing their nursing education. Dr. Cuellar is currently the editor-in-chief of the Journal of Transcultural Nursing and has published in peer-reviewed journals, as well as several book chapters related to her research area. She is currently funded with the All of Us research program with NIH in collaboration with the National Association of Hispanic Nurses. She was awarded the recognition as a Transcultural Nurse Scholar, a recognition of her contributions to the science of culturally congruent healthcare and diversity. Dr. Cuellar is the immediate past president of the National Association of Hispanic Nurses and is a fellow of the American Academy of Nursing. Dr. Cuellar's full bio is available on my website, alirtayeb.com. And I want to welcome to the show, Dr. Cuellar. Welcome.
Well, thank you. It's such an honor to be here. It's looking at all the other speakers. I hope I can match up with some of those excellent speakers you had.
I'm sure you will. I have no doubt. So thank you for your time. I know you're busy. Let's start the first part of the show. And I ask you, how did you get started in the world of nursing?
Well, it was a long time ago. I have to tell you that. My mother and father had 6 daughters, and she wanted one of them to be a nurse. And I was number 5 of 6. And I knew my baby sister was definitely not going to do it. But anyway, I had actually gone to pre-med and I didn't like it. And I was with my roommate and I thought about some other options. And she said, why don't you go into nursing with me? And I said, okay. And I kid you not, that is how I got into nursing. It was the best decision that I've ever made. God put that girl in my life for a reason, because I feel like the choice for nursing as a career and a profession can be a lifetime full of opportunities. Now, if it's just a job, you're going to probably hate it, and you're not going to want to be a nurse, and you're going to want to figure out how to get out of nursing. Or maybe, your mother has been in nursing or whoever, and they just hate nursing, and they tell you, why do you want to go into nursing? I would guess it's because they see it as a job and not a profession. And there is a big difference. In a profession, you're committed, you're dedicated, you continue your education, you continue to grow and move, up the ladder, or it doesn't even have to be a ladder, but you continue to grow personally in yourself. So, and you're never stagnant. And nursing is like that. If you want to go from one area to another, you can do that. And you are qualified as an entry-level nurse in just about, any position, but you have to be willing to learn, and you have to maybe move and and study and, do what you need to do. I will tell you that when I graduated, I wasn't sure what area I wanted to go into. And I had 3 areas, and the area that I chose was critical care nursing. And again, I went right into critical care nursing. And some people say, oh, you need to work on the floor, or you need to do this, or you need to do that. I don't agree with that. I got some of the best, if you want to call it continuing education. I went to Baton Rouge General Medical Center, which is in Louisiana. They had I want to say a 3-month, I can't remember, orientation. So I got extra classes. So I was able to really perfect my skills. Someone was always watching me. Someone was telling me what I needed to do. Someone was guiding me. And I think it's very different than if I had gone on the floor and they just threw you out there and you do what you want to do, or what you think you're doing. And I think sometimes you might even develop bad skills. So along that line, if you're if you're listening to this and you're an undergraduate and you're wondering if you should go into a specialty area, I would say if you have a good program that's going to help, in the transition, absolutely.
Yeah.
So anyway, after I started working there, I knew that I wanted to teach. And so, again, people say, oh, you shouldn't go back you go back to school for at least 2 years so you can get that clinical practice, I did wait 2 years, and I went back and got my master's at LSU. But I don't think that's necessary either. I've seen students go from their bachelor's right into an NP program, and it's the same principle that I was just talking about. You're just continuing and you're getting a better skill set, and it's really gelling, within your mind or your thoughts. So don't let that scare you either. If you really want to do it, you do it. You do what's your passion. You do what you really want to do. So I started teaching, but I always worked. I always stayed in clinical, sort of dabbed in different things. I did home health. I did prison nursing. I did school health nursing. I did a little bit of everything, and I did long-term care. And I just loved it. I love being a nurse. I love that I can make more money if I need to, or if I need to sit back, whatever. But the teaching piece was very important. So I knew that if I wanted to stay in teaching or go into teaching, I had to get a PhD. And I say a PhD because that is a terminal degree for education, for if you want to teach in a university setting. There's that big controversy. Is a DNP a terminal degree? And it's a clinical terminal degree, but the highest degree that you can get in your profession is considered the terminal degree. And in nursing, you can get a PhD. So I wanted to get the PhD because I wanted to, continue on and go through the process, because you have to get your PhD to get tenured in most universities. To get your promotions and things like that. That's a whole nother subject that is definitely, I teach in the DNP program, and I love those students. They are great. And, people used to talk about the ivory tower, and that there was people that did research and people that practiced, and there was nothing connecting it. Well, that's what the DNP does. The DNP connects it. And it can bring so much of that evidence that we have into practice, and it's just a great program and a great connection. So I don't know how we didn't do it, but why we didn't do it sooner. It was very controversial when it started out, but anyway. So I've been teaching for 32 years now, and I'm a full professor, and I am tenured. I've gone through the ranks, and I've gone through the tenure process, and it's not easy. So if you hear people say teaching is easy, it is not easy. It is a challenge, and it is a lot of work. It's a whole lot of work. So that's how I got into nursing, and that's how I got into education, and that's how I got to where I am today.
That's fantastic. Thank you for sharing that. Now, I know you mentioned that the DNP thing that you mentioned, that is so true. And I think it was at a conference, I don't know, it was about 3 years ago or so, where there was a DNP cohort, and it was and I went and I sat in on that sort of a breakout session, and there is so much variety it seems like, in what DNP programs cover. And not, there just, at the time, there just didn't seem to be any consistency on what the DNP was really for. And nobody could really agree on what the DNP was for. And I understand DNP, that the programs are fairly new. I mean, the Cal State system, just only the last couple of years, California agreed that they were going to allow their California state university systems to have DNP programs. And my university that I teach at now was one of the pilots universities that was teaching the program. I was under evaluation for that legislation that went through. And so, in your opinion, how do we get the DNP programs to be more consistent along the way? Because the DNP, when it first came out, they said it's a clinical track where, it was for like nurse practitioners, right? And then it went into administration and other executive leadership, and all this other stuff came out. So can you expand on, since you have that experience and it just piqued my interest, it seems like you have a strong opinion on this. So I'd like to hear about that.
Well, first of all, I think there's a misconception that it started out with nurse practitioners, because it did not. The NP stands for nursing practice, and it's been around now for about 10 years. And it was, like I said, it was very controversial because there was a lot of concern that nurses would choose the DNP route rather than the PhD route. And the PhD is developing knowledge and science, and many did not want to lose that focus, and were concerned that our PhD numbers would drop. And in fact, they didn't drop, but they haven't risen that much. Now, our number of doctoral prepared faculty, which includes DNPs and PhDs, has gone up. So you'll see that number reported, but the number of PhDs has remained pretty constant. So it started out with nursing practice, and that was leadership, that was midwifery, that was CRNAs, that was nurse practitioners, anybody that worked in a clinical setting. It was not intended for educators. It was not intended for researchers. When you do a scholarly project, that is not supposed to be research, and you are not supposed to call it research. It's not a dissertation. It's a scholarly project. And even now, people, I hear people say, "Oh, I'm working on my dissertation." I said, "Oh, you getting your PhD?" "Oh, no, I'm getting my DNP." And no, you don't. That is not part of the essential criteria that AACN has put out. So, you have to use the correct terminology for these two. So, I would say, if you have any questions, you need to look at the essentials, the AACN essentials that tell you what the DNP program is. Now, a lot of people look at that and they have a broad definition of it. They read into it. It's sort of interesting because, to me, it's and I hope I don't hurt anybody's feelings about this, but it's sort of like the ADN and the BSN. And what is the difference? And how people describe that, and what are they what are they saying, and so it's sort of that fine line there. But all of those roles are very important in patient outcomes and in making sure that we're providing the best patient outcomes. But we see DNP programs that focus on education, or DNP programs that focus on research, or they have more research classes or whatever. And I think it really needs to be what your strategic plan is, or your goal of your university is. And you just have to be very careful about making sure you're following the essentials, because if not, you could lose your accreditation related to that. So I'm all for education, and if you're learning and if you're doing something that's improving patient outcomes, just be careful that you know what you're doing. And I've had many a DNP student that said, "I had no idea what the difference was, and I would have done a PhD program because I want to do research." And they thought that the DNP was research, and it is not. You follow research process, but you're actually pulling data that's been done and implementing it and testing it. So there's a fine line there. Well, isn't that research, but you're not developing new knowledge. You're not developing a new idea or, that scientific piece that's been done and now you're testing it. So,
Yeah. And I think that's thank you for clarifying that, because a lot of people like I talk to, people that've been around for a little longer than me, in the world of nursing. A lot of them actually, have said like, oh, this was supposed to be for nurse practitioners, so they have equal say in when they're sitting in with physicians, and they should have a doctorate as well. And a lot of those impressions are out there. And you're right about the research piece, because there are universities, and I know people who've gone through the program where they're almost going through a PhD program, it feels like, except they're finishing like in 2 years. And I'm like, how are you doing everything in 2 years? And it's just so, and I think you're right. There is a fine line between translation of research into practice. And I think that's what's missing. And that's where the DMPs are able to fill that gap. So absolutely, I agree with you. So thank you for that. I learned something. Not that I'm surprised I learned something. I learned something.
Well, I learned something every day. That's a good thing. We should learn something every day.
That is. So thank you for that little piece of knowledge. Now I know your own personal work, and I love the complementary and alternative medicine. A good friend of mine, who I was in the Navy with, came out of the Navy and started doing Eastern medicine. Mm-hmm. And was certified, and he did that for many years in Texas. Actually, he moved back home to Texas, and he opened up his own shop, and I know it works. What is how do we incorporate that piece into nursing? Because I don't think we talk about it enough. We don't teach about it at all, I think. How do we what has your experience been with alternative medicine and complementary medicine, and where do you think it lives in the world of nursing?
Oh, I think it's very important in nursing, and I think we do a lot of it and we don't even realize that we're doing alternative practices. It's ironic that it's called alternative medicine, because medicine it's not medicine, it's practice. Anyway, these alternative practices, many of them work and many of them don't work, and as a healthcare provider, whatever type of healthcare provider is, you need to know, get at least a little bit of a background. It's not taught in programs. It's more taught nowadays. Medical schools are starting to teach it, but again, it depends on the program. If someone thinks it's important enough to have an alternative medicine course in the program, then they'll do it. But it's sort of like culture, but now culture is a big thing and everybody wants a culture course or whatever. But it's just a choice. Where do you want to fit it in? Could it be an extra assignment when you're doing med-surg nursing, or when you're looking at pain management and things like acupuncture or whatever? What type of alternative medicine? Herbs are that's a very, very touchy issue. You cannot say any herbs are for treatment of a certain illness. You have to be very careful about that. Herbs, different people make different types of herbs, and the quality is very different. When you have pills, or since it's not FDA approved, you can have a different, like a valerian. I did research with valerian. You might have a valerian tablet with very poor quality, or a lot of fillers in the tablet, and it depends on how it's made. And if it's poorly made, it doesn't get absorbed in the body. The whole pill gets expelled, pooped out.
Yeah.
So there are so many variables that have to do with that. Now, herbs, doing research with herbs, you have to have a mechanism of action. You have to know. So for valerian, we knew that there had been some pharmacokinetic studies that showed that valerian worked like benzodiazepines. And so my research was looking at restless leg syndrome And benzodiazepines are used to treat restless legs. So there was a connection. Okay, well, then would valerian work in place of a benzo for RLS? So there's got to be a connection there that you can make to say, yes, I want to do research in this area. You can't just pick anything out of the sky and say, oh, let's do this. There's got to be a mechanism of action there. So, but yeah, I also did a publication with a student that was interested in using honey for wound care. And there had been a long time ago, people used honey for wound care. That's been used. That you wouldn't think about that. There's so many things out there. But how would you incorporate it? It's got to be one person that has the passion for it, or one person that wants to see it, or one faculty member that wants to do a course in it, or anything along that line. There is some I think there's something about making sure you have it somewhere in the curriculum, but it's just a very small amount. So the National Center for Complementary and Alternative Medicine which I think they have a new name, but that is an excellent website from NIH that I would say look at that as a resource. They have a lot of the alternative medicines that you can click on, and they show what evidence there is. Acupuncture has a lot of evidence. Chiropractic medicine has a lot of evidence that that it works. They don't even like to be called alternative, because they have so much evidence that says, no, this isn't alternative, this is real. So yeah, I think we do need to put it. There's the Holistic Nurses Association. There's a group with the holistic nursing. If this is something that any of you that are listening are interested in, it's a good area to be in. And there's not many of you, and making your niche in nursing and being a future leader, that's how you get there. That's what you do. You find your passion and you stick with it, and you say, this is what I want to do. And you become better educated. You go to classes, you get certified, you get your PhD in it, or do research with it. You make sure that you know as much as you can about it.
Yeah, and I think you're absolutely right. I think one of the issues is especially from an undergraduate level, our nurses are just simply not exposed to all the different areas they can practice in. Like I said, we don't talk about this. I know my buddy, before he left alternative medicine to do some work with another organization that works with veterans and mental health issues. He made a concoction for me, that was going to be a tea concoction for respiratory illnesses. He gave it to me. He said, whenever you have a cold, just take, he gave me the dosage and everything. I just remembered it smelled horrible the first time I made it. I was like, oh my God, he's trying to kill me. But hey, it worked. That's all I can say. It worked. Whether my body didn't want another dose of it, whatever it was, it kicked out whatever that was in the system. So I know it worked.
Another practice is mindfulness meditation that's real popular right now.
Right.
And the spirituality route of mindfulness, there's a lot of things related to that there's just literally thousands of types of alternative practices.
Yeah, I agree. I mean, even some of the stuff, I think, as you're talking, some of the stuff that we teach in the undergraduate level, where we talk about music therapy for pain management and things like that it is alternative. We don't call it that.
That's right.
We don't bring attention to it. We just use it. So, and I think part of that has to do. I think the part that I think why we need to concentrate a little bit more on that is gaining not only understanding but acceptance of the practices that are out there that people do on their own already, whether it's cultural or it's from their hometown or their home country or whatever it is, the practices that people have adopted. I think we need to just be more open to those and understand how it affects them, how it affects their bodies, how it affects the whole concept, and how do we integrate that. So I think that
now and then you start crossing over, which is exactly what happened to me. You start crossing over to cultural
Mhm.
acceptance, cultural competence, cultural humility, whatever the terms you want to call. There's a lot of different terms. They change. They cultural humility is a popular one right now.
I've been pushing cultural humility for years.
I know. I know.
Like cultural competence never made sense to me. I'm like, I'm not even competent in my own culture. How
That's
am I
right.
going to be competent in somebody else's?
That's right. That's right.
So,
Oh, there's. I think there's 4 or 5 of them. There's probably more than that. But
yeah.
anyway, you've got to look at a person's culture and accept what they use and what they practice and their cultural medicine, if you will. Like Asian or there's the American Indian. There's just a variety of them that what do they use and why is ours any better? Really and truly, body, mind, and soul. If they don't think ours is better and they think theirs is better, then theirs is better, right? It's like you can't go in and just barge in and say, oh, you got to do this, and when they don't accept that. So I did a webinar yesterday on vaccine hesitancy, and we were talking about culture, and it's the same principle. Based on a person's culture, you've really got to get into what they believe and what they are thinking and what they understand. What is their health? What is their education? What is their kinship? What is their socialization? It's all those things that they decide what their care is going to be. And we can't go in and just push it on people that have vaccine hesitancy that are really being challenged by our belief system, the COVID-19 and all that. So there's several theories, cultural theories that could sort of guide you and help you look at that and decide. One of them is Madeline Leininger's culture care theory, and she talks about a lot of different things that make up culture care, and it has to do with alternative medicine and all of this stuff. So I would a lot of people don't like theories, and they say, oh my God, I don't want to study theories, but we all practice on a theory, whether you realize it or not. You practice using a theory, and understanding it can just know that you can't practice without a theory. Whether you believe that a patient has a right to do this, or it's the family, or whatever, you are practicing on a theory. So, and it's a theory based on your cultural beliefs. I'll put that in real quick.
It's very true. It's very true. And I was sort of disappointed when I had gone through my undergraduate program full of nursing theories. When I came back to teach, the theories have kind of disappeared. And a lot of schools have moved away from teaching theories. So when you talk about theories to students, like later, I usually have them later in there as they're going out the door. So when I talk about theories, they're sort of confused, and like, whether you know it or not, you are practicing under some theory, you just haven't named it. So it's interesting you bring that up, and I think it's kind of unfortunate that we've moved away.
We're one of the few disciplines left that we're using theories. And you learn about theories and you want it to guide your practice or your research or whatever. But we don't really require it in manuscripts anymore. Like when I first went into my master's program, we had a nursing theory class. And then when I did my doctorate, we had a nursing theory class. It was like theory was just pushed down your throat. And we really didn't use it that much. I mean, but it was so important to learn it, because we do use it. Again, just like I'm talking about the question yesterday was, how do we get through people's cultural beliefs to get them over this vaccine hesitancy? And I said, go to Madeline Leininger's theory. You can see, that's what you do. Look at her theory. It's been tested to, I don't want to say break through their walls, but to improve that cultural understanding and make sure that the people that are making decisions are there together, those kinship ties. And What is their education? What do they believe about this? So it's
Yeah.
there.
And I think from a framework perspective, theories are so important because it puts everything in a concept for you, right, from beginning to end. Even though you have to fill in the blanks in the middle, it really helps with that concept. And even like when I was going through my undergraduate program, we talked about Orem, left and right, and it was incorporated into everything, and everything we did had to have something Orem related. And
Yeah,
even
and it was built into the curriculum. Your
right,
curriculum was developed based on Orem, or
yeah.
we did
So,
Orem.
so like when my girls were they're still little, but when they were more little, like when they fell, I'm like, oh, get up, just shake it up. I'm like, hey, that's Orem. I'm teaching her how to self-care and all that stuff. So, right? You put up,
Yeah, a little bit.
So anyway, I as just because it's been taught to me over the years, and I've used it for my own research. I think it gives me a good foundation to build whatever it is I'm building. It gives me a framework to work off of instead of trying to create my own sort of frameworks that I think sometimes may lead you down the wrong path. So yeah, thank you. Yeah, so let's talk about, if you don't mind, just sort of in the same arena, but a little diversion. So you are the immediate past president of the National Association for Hispanic Nurses. Can we talk about the organization a little bit, and how can we bring in more diversity in the world of nursing, because we are still primarily mostly white, female profession. So how do we increase that, and just want to have your take on it?
I don't know how.
Right?
That's a big question.
Yeah.
No, I'm kidding. I'm teasing you. So the National Association of Hispanic Nurses represents Latino nurses or anybody interested in Latino healthcare. You do not have to be Latino to be a member, but the majority are Latinos. We are not focused on any one area in nursing, so we're not like cardiovascular or pediatrics or whatever. We are more of a service organization that we do a lot of community-based grassroots projects if we do projects. We have, right now, we probably have about 1,700 nurses are not members in our organization. And we do have some research grants that we have been asked to participate in, but there are a lot of them, some of them are program grants. I'll tell you, one of them is the All of Us Research Grant, which is looking at precision medicine. And it is a genetic, part of it is a genetic study, but there's other factors that they look at as well. But we want to improve the health outcomes, and they're looking at the precision medicine. They're looking at the genetic makeup to see what are the best interventions for Latinos or Asians or American Indians or whatever. So they want to get 1 million people, and they really want to try to represent as many underrepresented groups as possible. And so we have partnered with them to increase, to go out and educate Latinos and to increase that visibility of not only but the All of Us research program. We do, at one point in time, we made up a very small percentage. It was only like 2 or 3% of all nurses were Latino. And now we're up to about 10 or 11. We've really worked hard on it, trying to get people, but I also think it's the way people are reporting. And I want to say that Latina, being a Latino or a Hispanic, is not a race. It's an ethnicity. So you have race, you have white, you have Black, you have Asian, you have Indian. Those are races. Ethnicity is being Latino. You can be white and a Latino. You can be Black and Latino. You can be Asian. Like, let's say you are Asian and you were raised in Mexico. Well, and you speak Spanish, you could be Asian, and you can be Indian and of course, we're talking about the Aztec and many of the that group that is Latino. So for many, many years, they would say, Latino, not white. And that just aggravates me to death, because that makes me decide whether I want to report white or whether I want to report Hispanic or Latino. So it's just, okay, what am I going to be today? When I first moved to Alabama, they did that. And I called them and I said, look, if you really want a good representation, you need to separate out being Latino or not, because that is not a race. And they did. And those numbers increased a little bit. When you do research, you need to be very careful about how they're reporting research, or is it really accurate? So that is a big topic. That's a big issue, not only in research, but how we report Latinos. So that number did increase to like 10 or 11%, but our organization has been fighting for that and educating. And, we had a big grant about 5 years ago to educate Latinos about nursing. And we started at the junior high level. We don't wait until they graduate. We start very early. And the reason why is because the guidance counselors would often tell Latinos, oh, you can't do that. You need to go to a technical. You don't need to take science courses. You're not smart enough, da, da, da. So, we did work with some guidance counselors and said, you gotta stop that. You can't do that, and that was important. There's so many barriers for Latinos to get into nursing programs, and it's not only Latinos, it's all minorities. Well, I'm not going to say that, because if you look at Asians, they have very high scores with sciences and stuff. But Latinos do not, and there's a lot of reasons. If they're migrants and they're going from school to school to school, there's never one person that they can mentor or that mentors them, or there's never one way you can follow with them. If the best schools, they may not be going to the best schools because they may be in poverty. They may not have access to computers. Families often say, you don't need to go to school, you need to go work because we need money. The entry level is usually an ADN degree. And when they get there, families will say, why do you need to go back to school? You're making money now, so you don't need to go back to school. So you don't have the advanced practice nurses or the PhDs or whatever. Less than 1%, when I first got my PhD, less than 1% of Latino nurses had their PhD. Right. That's how rare it was. The problem with that is when you are Latino and you go to nursing school and you go and you say, where are the people like me? Where are the faculty members that are Latinos? And when I went to nursing school, there wasn't one Latino. There was not one Latino faculty. I had in my HRSA grant that is just ended, I had students that tell me they didn't even know that they could get a PhD. They didn't even know that there was advanced degrees in nursing, because they had never seen anybody that looked like them that was teaching them or that was in leadership areas, levels in healthcare. They didn't see Latino doctors or people in the offices. There were no Latinos. And, now we see more, of course, because that number is increasing. But, that's why we just haven't had those increased numbers. And we're seeing more of them. And I think we're seeing, Latinos are seeing that this is a possibility, and there's a lot of resources available now. But yeah, and as the future of nursing 2030, one of the main goals was, increasing the workforce diversity. And they're talking about a broad range of groups. The National Coalition of Ethnic Minority Nurses Association is a group, it's 5 organizations. It's NBNA for the Black nurses. It's the Asians. It's the Philippines, and then the American Indian. and you can, it's NCEMNA. And remind me, I'll put that, you said you put some websites or whatever. We can put some of these websites up. If any of you are underrepresented or minorities in this group, you should join your organizations that can support you. We provide scholarships. We provide research funds, not much, but but you'll see people that look like you, and we at our conference, it's important that we get our students there so that they can see what you can be when you grow up, and even me, it's like I see, oh my gosh, I want to do that, so it's important that students see people like themselves, or they'll never have role models, they'll never have mentors.
It's I as you're talking, you're making all kinds of wheels up here spin, but it's when you mentioned that, I do teach in the ADN to BSN bridge programs, and I use like I said, I use my podcast in my classes, and so many of my students who are Latino, they really gravitate to some of my speakers that are from the same area or from the same background specifically, and a lot of them do say, I didn't know I could do this, or I didn't know this was a possibility. Now I'm going to look into it. So you're absolutely right. I don't think we have enough representation, especially in academia. We don't have enough representation. And it's
funny, you're in California.
And I'm in California. I'm in LA. One of the most diverse places that you could have, and we still don't have I think enough representation where, and so I 100% agree. We don't have it, and it's something that we need to, as a profession, we really need to work on. And it's interesting. You mentioned you start at junior high. I was some of my other speakers are like, yeah, start elementary school. Pretty soon it's going to be preschool. We need to get them early, because by the time they're in high school and they're already in college, it's too late. It's too late.
Or they want to go into medicine. They don't even think about nursing.
Yeah, or they want to go into medicine. That's true. Very true. So thank you for that. Thank you so much. You've shared so much with me. Anything else you want to share with our audience?
Well, we didn't talk about the Journal of Transcultural Nursing.
Oh yeah, absolutely. Yeah, definitely. Yeah, I don't know how let's talk about that.
Well, just briefly, because I know our time is getting short, but Lord have mercy, if you had asked me if I would ever be an editor of a journal back when I was getting my baccalaureate degree or my master's or my doctorate, I would have said no way. But this opportunity came up, and I said yes, and I applied, and I got the position, and it has made such a big difference in my life. And I just want to say that you never know what opportunity is going to fall in your lap. And I would challenge all of you, never say no, and always think of, this could be something that, I believe in God. So I'll just say this should be something that God put in your path, and don't be scared to try something new and different. And I started doing, I was the editor in 2012, I believe. It has been, I have 12 associate editors. We receive about 400 articles per year, and it's quite a big job to go through all those and work with people to get them ready for publication. It is a process, but I want to encourage all of you to think about, especially if you're master's or doctoral prepared, to think about how you can use your work and your education to publish an article. Everything you do in your schoolwork should be focused on your job. So if you take a research class and you're being asked to, look something up that you're interested in. Don't just do it because it's just to fill an obligation. Get the best that you can out of it. Work on becoming an expert in everything that you do in your classes, whether it's theory or quality improvement or informatics or whatever course you're taking. What do you, if you're an ER nurse and you see that you're concerned about XYZ, do all your stuff on that XYZ, but make sure it's making you become a better practitioner. That's what education is supposed to do. It's not just to be able to say that you have your master's or that you're going to sign your name, DNP or PhD or EDD or whatever. That is such a waste of time if you're doing that. And you really need to continue to grow and learn as much as you can and publish. The Journal of Transcultural Nursing focuses on culturally congruent healthcare, meaning that we're trying to identify the best ways to treat different cultures that is congruent, that we can do, and the different cultures we can work together so that the health outcomes are better. We did redefine what culture was. It used to just be that it was race and ethnicity, but culture is so much more than that now. It's age, it's sexuality, it's where you work, it's organizational. Military has a specific culture where they have to, work in. It's gender. There's just so many things that we use and that can define culture.
Yeah, thank you. As you were talking about this, and I'm thinking, and my research is veteran centric, so I'm like, hey, maybe I need to send you a manuscript.
You have to focus on the culture of that, but absolutely.
Yes, there's definitely a lack of information for veterans care in the civilian community. So yeah, definitely.
Oh yeah, that's a big issue, especially around mental health.
Oh, especially. Yes, absolutely. I agree. I have, I don't mind sharing this, but I was diagnosed with PTSD after my service. I was diagnosed with PTSD. And the first thing that I saw a therapist, and the first thing out of his mouth, he said, you should go to the VA. And I wasn't in the VA system. And it just showed right there, it showed me that how civilian healthcare providers don't know the VA process. And it would have been, like maybe, like 6 months to a year by the time you're in that system. So when you have a need and you're trying to meet it and you're not in the VA system, and a lot of veterans are denied the VA healthcare because of their discharge status or their own experience with the VA, they're not in that system. So it's super important that we get our civilian healthcare workers up to speed and taking care of our veteran community. So thank you for that. So you're making my wheels spin. So
good. I like that. Maybe I need to write. I want to make your wheel spin.
Yeah,
that's a good thing. I like it when people make my wheel spin, and when I go to a conference or whatever, and I just have a list of things. I'm so excited and motivated. And that's another thing I would encourage anybody that's listening to this is make sure you go to your conferences and get your extra boost of energy for your profession and for what you do. I don't see how I could be where I'm at today if I didn't, have my professional organizations. I don't know how people I don't know where people get their continue on, because I need my boost.
Yeah, absolutely. I miss in-person conferences. The online stuff is great, but the energy I get out of in-person conferences, I am not getting out of these online stuff.
But I can't wait until this all is over, but it will be over probably another year. I think it's going to be another year.
Yeah, I agree.
But last year when someone said, "Oh, we're going to be in this for 2 years," I was thinking, "Oh my God, please don't let that be. Please don't let that be." And here we are. It's probably going to be another year.
Probably another
Please
year.
get vaccinated. Please get vaccinated.
Yes, please. So thank you so much for your time. This has been fantastic, and hopefully we can stay connected. And yeah, so thank you. I appreciate everything you've shared.
Yeah, and if anybody wants to contact me for any information about NON, about all of us, the research program about all of us, y'all can all join and be a part of all of us. And there's a lot of people in California that are doing it. So I would really encourage you to be a part of that as well. Yeah, culture. Great. I'm happy to talk to anybody.
Thank you so much. Thank you. I greatly appreciate it. we have been listening to Dr. Norma Cuellar, and we shall thank you again for your time, and we will see you soon.
Thank you. Thank you for having me. It's been a pleasure.
Thank you. You've been listening to the RN Mentor with your host, Ali Tayeb. Please don't forget to visit www.alirtayeb.com. That's www.alirtayeb.com for podcast notes and resources, and don't forget to subscribe. Until next time, I wish you fair winds and following seas.